ADAPT TP is sort of a part of the ADAPT umbrella, which is a trials series for early breast cancer, looking at all different subtypes with the overall aim of avoiding overtreatment, but also enable more subtype-specific therapy in early breast cancer. And in HER2 positive, we did a series of neoadjuvant trials, and ADAPT TP is the first one in the hormone receptor positive HER2 negative space. The trial design is a 3-arm with T-DM1 in 2 arms, one with and one without endocrine therapy. And this sort of control arm, if you want, at that time was trastuzumab plus endocrine therapy. And then after surgery, if patients had a pCR, it was up to the physician and the patient to discuss whether they wanted more conventional chemotherapy or just the antibodies for the remainder of 1 year, which would have been trastuzumab at the time. And in patients with non-pCR, standard chemotherapy and anthracycline taxane sequence was mandatory. What we did, the primary endpoint was pCR. So we looked at the pCR that was already a couple of years ago, published in JCO in 2017, and we saw 41% total pCR. So that is breast and lymph nodes, no invasive residuals in 41% and only 15% in the trastuzumab alone arm. And as I said, after the non-pCR patients needed to get standard chemo, but also after the pCR was optional. So a good third of the patients did not get further chemotherapy in the T-DM1 arms. And what we saw and published at ESMO last year was that the pCR is predictive of outcome, quite strongly so. And in patients with pCR, there is no survival difference whether they had additional chemotherapy or not. So that was about a 93% 5-year IDFS rate, and the non-pCR patients had less, only 82%. And this year at ESMO, we now presented the biomarker data from the trial with regard to outcome. Yeah, what we looked at several biomarkers. We looked at RNA expression profiles, we looked at subtypes, we looked at immune markers and PIK3CA status. So maybe the 3 most important findings, which I also presented at ESMO in a mini oral, was that the immune markers, like for example, PD-L1 in the immune cells, but also CD8, was predictive of outcome, and it was predictive of outcome stronger than it was predicted of pCR. So this is apparently a factor which strongly influences outcome, and we were surprised to see that that was more so than for the TILs. TILs also predicted outcome, but marginally significant. So immune markers are strongly associated with favorably associated with patient outcome. The second marker we looked at was the PIK3CA status. We had about 16% with a mutation. And we were kind of surprised to see that impacted not only pCR, but also outcome. Patients with the mutation had a worse outcome. Like, for example, IDFS in the wild type was 85% at 5 years, 88%, and only 80% for the mutated patients. And if you look at the T-DM1 arms alone, this difference is even stronger with 90 versus 68%. So that is a bit in contrast to the previous findings, like from the Emilia trial in the metastatic setting, where they said that PIK3CA status does not impact outcome in patients who are receiving T-DM1. So that, I think this is something we have to keep in mind for further studies. And the last thing we looked at was the molecular subtypes. We saw that about almost 80% had a luminal subtype in this trial, and 21% had a HER2 enriched subtype. You have to remember that this is hormone receptor positive, HER2 positive early breast cancer. And even though the luminal A tumors did not have such a high pCR rate, HER2 enriched had a much higher pCR rate with this HER2-directed therapy. Their outcome was just best at the 5-year mark with almost 90% IDFS. So I think our conclusions from these data were with regard to the subtypes that if we design further trials in HER2-enriched populations, maybe we can go by pCR as an endpoint and then individualize therapy according to that. But for the luminal A subtype, definitely pCR and outcome need to be considered for de-escalation regimens. I think our results are just complement the whole picture we now have in the HER2 positive space with the ADAPT trials. We also have the data from the hormone receptor negative trial, which we presented at ASCO earlier this year. And I think what we learned is from all the trials that de-escalation trials are possible, and you can do them and individualize therapy after surgery according to pCR status, but there is certain subtypes where you also need to take into consideration the overall outcome. And this is particularly true in the hormone receptor positive setting with the luminal A subtype, because they have a low pCR rate, but still a very good outcome, probably because endocrine therapy is also important for them. But nevertheless, de-escalation trials are safe for patients. pCR is predictive of outcome. Additional chemotherapy may not be needed after pCR. And from this particular study, ADAPT triple positive, we have to remember that PIK3CA mutation is a negative prognostic factor in hormone receptor positive, HER2 positive early breast cancer in particular, according to the meta-analysis by Dr. Leubel et al. And we can just confirm that also for an ADC. So it's going to be interesting to see whether, for example, this is also true for TDXD, and whether we find the same results in our ADAPT triple positive 2, where we have PARCLI plus dual HER2 blockade as a de-escalated regimen. And it'd be interesting to see whether the biomarkers have the same impact there or different impact.